All right. Good day, everyone. My name is Onowori Victor. I am a neurology applicant, and I am also your host for the Neuroclarity podcast. I will be doing the Ching Cheng's comprehensive review in clinical neurology. So this is basically our chapter two. We've done chapter one already, and in chapter two we've done questions 1 to 11. Our previous question was on the artery of Pecheron, which I found very interesting. Um, this particular episode is going to be questions 12 and 13. Yeah, so question 12. A 49-year-old woman with anxiety, depression, hypertension, and diabetes presents to the emergency department with a sensory deficit affecting her right face, arm, trunk, and leg, which started yesterday in the evening. The symptoms reached their peak on the morning of presentation. There are no motor deficits on examination. Which of the following is correct? A. No further workup is needed and the patient can be discharged from the emergency department. B. Given the lack of motor deficit, her symptoms are most likely related to anxiety. C. The most likely location of this lesion is in the cortex. D. Cardioembolism is the most likely etiology. And E. Small vessel disease is the most likely etiology. Now that we've taken a look at our question and our option, I honestly feel that this is a very interesting and often underappreciated type of stroke. This is what we call a lacunar infarct, and our case actually involves a patient who presents with pure sensory symptoms. There are no weaknesses, no cranial nerve pulses, just numbness and tingling, and that can be a clue. Now, this kind of presentation is classic for a pure sensory lacunar stroke, which typically results from the occlusion of a small, deep penetrating artery. These arteries are especially vulnerable in people who have chronic hypertension. Now, while diabetes and hyperlipidemia can also contribute, hypertension is the main culprit in here. So, what actually happens? Now, these tiny blood vessels undergo a process which we call lipohyalinosis. Let's say it again, lipohyalinosis. And basically, the vessel wall degenerates over time, it becomes narrow, and eventually it gets blocked. Atherosclerosis in nearby large arteries may also play a role, either by narrowing the entrance to these small branches or allowing the embolic materials to lodge into them. Now, lacunar stroke tends to occur in very specific location, and it's very important that we know about these specific locations. There are six of them. The first place is called the putamen, the second is the caudate nucleus, the third is the thalamus, the fourth is the basis pontis, the fifth is the internal capsule, and the sixth is the deep hemispheric white matter. And depending on the exact location, you can see some well described lacunar syndromes. So let us begin with the big ones. We have one, the pure motor stroke. Now, this usually affects the face, the arm, and leg equally, and it most often happens in the posterior limb of the internal capsule, supplied by what we call the lenticulostriate branches. But you may also see it from lacunes in the ventral pons. We also have what is called the pure sensory stroke, and this is something like what we have in our patients. Now, in pure sensory stroke, you have hemisensory deficit affecting the contralateral face, arm, trunk, and leg, and this is usually as a result of a lacune in the thalamus. Next, we have something we call the clumsy hand dysarthria, and this usually presents with slurring of speech and clumsy hand, usually on the same side. Most commonly, it is due to a lacune in the paramedial pons, but it may also occur with infarct in the posterior limb of the internal capsule. We have another type of lacunar syndrome called the ataxic hemiparesis, and here the patient usually has weakness and incoordination on both sides. But something classical about this is that the ataxia is way out of proportion to the weakness, and this can result from lacunes in the pons, in the midbrain, the internal capsule, or even in the parietal white matter. So we've mentioned about four lacunar syndromes, which includes the pure motor stroke, the pure sensory stroke, the clumsy hand dysarthria, and the ataxic hemiparesis. Now, here is something that is very clinically important. While lacunar infarct can present with sudden onset, many actually follow a stuttering progression. So that means that the symptoms actually evolve in a stepwise fashion. usually over minutes, hours, or sometimes even days, and they can easily be mistaken for non-vascular cause if you are not thinking about the lacunar syndrome. So what should we do? Your go-to imaging here should actually be an MRI with DWI or diffusion weighted sequence. This is actually the most sensitive tool for picking up an acute lacunar infarct. Now remember, if you suspect a stroke, the first thing you need to do is actually to do a brain CT. Yeah, brain CT is less um, expensive, it's quicker, and it's faster. And remember, time is brain because you want to rule out a hemorrhage. But the ideal imaging for a lacunar stroke is an MRI with diffusion weighted sequence. Now, how do we manage? Well, usually controlling the diabetes and cholesterol is very important. Strict blood pressure control is absolutely crucial in preventing further lacunar infarct. Since hypertension is the main driver behind the stroke, managing it aggressively is actually very key. Yeah, back to our options. We have A, no further workup is needed and the patient can be discharged from the emergency department. Now, this is so wrong. And why is it so wrong? You can't have a patient who is presenting with lacunar stroke, pure sensory stroke, and then you decide to just discharge this patient. You need to know what's going on. You need to halt the process. Yeah, so that's so false. B, given the lack of motor deficit, her symptoms are most likely related to anxiety. That's again false. C, the most likely location of the lesion is in the cortex. That's not true. Why is this not true? Because if it's a cortical lesion, you are going to have more than just sensory deficits. Remember that this is a pure sensory stroke, most likely a lacunar infarct. And when we say lacunar infarct, there are about six places that gets touched, which includes one, the thalamus, two, the pons, three, the putamen, four, the caudate nucleus, five, the internal capsule, and six, the deep white matter structures. So options D, cardioembolism is the most likely etiology. That is false. Cardioembolic stroke tends to cause something we call showers, and then you don't just see a sensory deficit, you may see multiple deficits. So that's false. Options E, small vessel disease is the most likely etiology. So that's true. Remember our lipohyalinosis. That's true. Question 13. A 52-year-old man with a history of smoking, diabetes mellitus, and hypertension presents with acute onset of left hemiparesis affecting the face, arm, and leg. He recognizes the left side of his body and acknowledges the deficit. His gaze is not deviated, which is the most likely location of the vascular occlusion. So A, trunk of the right MCA before the bifurcation. B, lenticulostriate branches of the right MCA. C, superior division of the right MCA. D, right PCA. And E, inferior division of the right MCA. All right. So, taking a look at this, let's walk through this case. We have this patient who presents with weakness. We said it's affecting the face, the arm, and the leg, but there are no sensory deficits. There are no language issues, there's no neglect, no visual changes, just motor weakness. Now, this is going to raise a kind of red flag for something we call a pure motor stroke. This is often due to a lacunar infarct, like we mentioned previously. So, where exactly is this lesion? Well, most likely it's in the posterior limb of the internal capsule, and in this case, it's on the right side. And what's the vascular culprit? Yeah, you got it right. The lenticulostriate branches of the middle cerebral artery. Now, this is a small but a very mighty vessel that supplies very critical areas in the brain. You can call them real estates of the brain. So, what do these arteries feed? One, they feed the putamen. Two, they feed parts of the caudate nucleus. In particular, they feed the head and the body of the caudate nucleus. Three, they feed the outer globus pallidus. Four, they feed the posterior limb of the internal capsule. And five, they also feed the corona radiata. So when you have one or more of these vessels occluded, you usually due to chronic hypertension, you can get the classical lacunar stroke syndrome. Now, here is where localization actually really matters. Going back to our options, if the main trunk of the MC is involved, instead of just the deep branches, the clinical picture will be very different. In fact, you will likely not see just weakness, but you will also see sensory changes. You will see cortical signs like aphasia if it's in the dominant hemisphere, or hemineglect if it's in the non-dominant hemisphere. Now, if you're thinking, can a division in the MCA cause pure motor stroke symptoms? Well, not quite. So, strokes in the superior or in the inferior division of the MCA typically cause weakness that is more in the face and arms than on the leg. Remember that for the leg, if you are to have weakness in the leg, you should have an issue with the anterior cerebral artery. Now, and usually they are often and usually an MCA stroke is often associated with other cortical signs. Don't also get confused with the posterior cerebral artery stroke. I think we had a very lengthy discussion about this in the previous video. Those ones usually present with things like visual field defects, sensory defects, and you will not see isolated motor weaknesses. So, in summary, if you see pure motor weakness without any sensory or cortical signs, think of a lacunar stroke, and most likely in the posterior limb of the internal capsule, usually caused by occlusion of the lenticulostriate branches of the MCA. So, options B, the lenticulostriate branches of the right MCA, is the right answer. So, thank you for tuning in to Neuro Clarity. If you found this helpful, you can drop a like, you can leave a comment, and until next time, stay curious, stay sharp, and stay clear.